Good afternoon, everyone. Welcome back to our first COVID-19 update for clinicians since July began. We were off last week for the 4th of July holiday, so we're glad to have you all back this week. I know it might take a few folks to get back into the rhythm of tuning back in at noon on Fridays, but we're glad for those of you who are here. We're going to do just a couple Menti questions again this week, so if you will go on your device to www.menti.com. You can do that on your laptop, on your phone. Enter code 521044, 521044. And you can just go through the questions. You don't have to wait for us to get to them during the presentation. You can answer them at your own speed. And then at the end of this, we'll have a Q&A. So feel free to put any questions that you might have about COVID-19 related things into the chat box. And our good friend here, Peter, will put them up on the screen for us, and we'll get to as many as we can at the end of the webinar. So today, well, first of all, I'm Dr. Michelle Fiskus. I'm the Medical Director of the Vaccine Preventable Diseases and Immunizations Program here at Tennessee Department of Health. And with me today is Dr. Adele Lewis, who is our State Chief Medical Examiner. She joined us, about 6 or 8 weeks ago and talked a little bit about COVID-related deaths, and that was, I think, when we'd had maybe just a couple in the state. So she's back today to talk a little bit more about death-related things and case fatality rates and the like. So first Menti question, what's the hardest thing about this pandemic in one clean word? And so we're seeing uncertainty, exhausting, compliance, balance, looming, uncommitted public, amen to that, inconsistency, fear, spread, testing, confusion, not knowing, fatigue, ponderous, ooh, that's a good word, divisive. Yeah, I think all of those apply, and I think we're all feeling all of those particular words at this time. We'd like to know a little bit about who you are. We like to have some information about that so we can help to make sure that the content that we give you each week is relevant. So pick one of the areas here, whether you're a pediatric generalist or specialist, an adult generalist or specialist, nurses, public health administrators, school health, whomever, or if you are someone else, pharmacists, they sometimes join us too. So let us know who you are. You can keep entering these things even after we go through the slides. And then for those of you who are on right now, have you ever been here before? It looks like right now all of you have. So that's pretty cool that you keep coming back. And we enjoy having you, and we really try to make sure that the content is something that is worth spending 60 minutes of your day doing. We've asked this question about stress all through this since our very first webinar back in April. And so this breaks down by however you identified yourself on the last slide. So we've lost the I'm good folks. At the beginning of this, we had a lot of I'm good folks, and we've seen these bars continue to shift down to the right, and then have now started to pick up a few folks week after week who are admitting that they're really stressed and feeling hopeless and just generally not doing well. I think we echo a lot of that here too, and there are days when you just hit a wall and you're just not exactly sure how you're going to keep doing this, and then you know, sometimes if you can take a little bit of time for self-care, oh, we got one person pop in as I'm good, so that's awesome. Thanks for that little ray of sunshine in this. So just looking at this compared to April 24th of this year, where we were, a quarter of us were good and 62% were stressed, but it's manageable, and now we're looking at, you know, more like 50% that are really stressed, or pretty stressed and worse. So, you know, it's definitely taking a toll week after week amongst all of us here. So just a reminder, I like to highlight this every time that we meet because there are times when you just need someone else who understands what's going on. So this is the physician support line. It's free. It's staffed by board-certified psychiatrists from all over the country, and it is available from 8 in the morning till 3 a.m., 7 days a week. And if you're a physician, you are welcome to click on that Call Now button on their website, and they will hook you up right then and there with someone who can talk to you and give you some support. And then for other healthcare workers or other folks who are involved in pandemic response, there is an emotional support line here in Tennessee for healthcare workers, and those hours are 6 a.m. to 10 p.m. Central Time during the week. And if you need that support, you're welcome to call there as well. And just make sure you're trying to do something to get some self-care. So we are now 177 days into our incident command system here. We stood this up here at Department of Health in the State Health Operations Center prior to our first case in Tennessee, which came 50 days later, 127 days ago. We still do welcome your calls if you have clinical questions about testing or quarantine or isolation. You can call that number 615-741-7247, and that is staffed 8 to 4:30, but then we'll also give you an on-call number if you need to get in touch with a physician for a public health-related emergency after hours, and that person is available 24/7. So if you need us for anything, you're welcome to call us. I was on call this past weekend, and sadly was kind of excited to have a call about rabies and not about COVID-19. So there are other things that public health deals with besides COVID-19. This has just sort of drowned out everything else going on for the most part. Globally, I like to try to give you some perspective about where things are headed. So our cases are up across the world by about 25% over the last 2 weeks, with global deaths passing 550,000 and somewhere around 38 million test results at this point. And then the global Epi Curve is down below, where you can continue to see this ongoing uptick that's actually gained a little bit of steam over the last couple of weeks. From the United States, we have passed the 3 million case mark for the U.S. now, and over 125,000 deaths, which is we're up, coming up on 800, right at I can't math today. What is that? 700,000 cases compared to 2 weeks ago. Notice that the U.S. per capita death rate or case rate has been increasing. So we were at 729, now we're at 938, and the deaths per capita has also increased in the United States from 35.7 to 38. And then the Epi Curves are down below. So the last time we talked, a couple of weeks ago, we had this declining Epi Curve in the United States. That's the orange line. And now you can see we're just over the last couple of weeks, we have taken a sharp upward turn in the U.S. Brazil, we've now passed where Brazil was. Brazil continues to have an uptick, but not at quite the trajectory that the U.S. is doing. But this is obviously really worrisome. And this is the 5-day new case moving average. So when we talk about flattening curves, so if you're kind of new to epidemiology and what outbreak epi looks like, on the left of the United Kingdom and Egypt, you can see what an Epi Curve is supposed to do during an epidemic or a pandemic. And so the United Kingdom, who has suffered the highest mortality in the world, had this very rapid surge in cases and now has come down really nicely down the other side, where they've brought their case numbers down. They've had a little bit of an uptick just over the last week or so. That's why you got that little up arrow on that one. And then Egypt similarly had a big uptick in their cases and now seems to be coming down the other side. But the U.S. has sort of had this swift uptick when everyone first realized this was going on, and then this slow, gradual decline, and now over the last 2 weeks, again, just this tremendous, almost logarithmic increase in the number of cases that we've seen. This is what the states are doing. This is the new confirmed cases per 1,000 population in states. So still the South Central United States is really where most of the action is happening, plus Arizona is still struggling a bit. California has had some recent increases in cases. Texas and Florida and South Carolina are all in surge, and they have exceeded their hospital capacity and are moving adult patients into their pediatric hospitals at this point. Alabama is doing a little bit better than they had been. They had a huge surge about a month ago in the Montgomery area, and they've settled down a little bit, but they're still pretty hot pink on there. And then we're sort of in the middle of the high numbers in Tennessee with respect to new cases per population. So there's a lot of talk about testing versus positive rates. So, and a lot of comments have been made about the positive case numbers are higher because the testing is greater, which is true. We have identified more positives because we are doing more tests. But there are states like New York State, which has the highest amount of testing of any state in the country, at 3.1 tests per 1,000 people in the state, that has a case positivity rate of 1.1% at this point. So a state that was the epicenter for COVID-19 activity just a couple of months ago now has a 1% positive rate, but is still doing a massive amount of testing. And then the worst performing of the continental United States when it comes to testing is Idaho, with 1.6 tests per 1,000 residents there, and their daily positive rate is 13.3% of their tests. So it's not fair to say that because there's more testing, there's more positives. We have states that aren't testing a whole lot, that have a lot of positives because they're only testing people who are sick. And then we have states that are doing a tremendous amount of testing that have low positive rates because they've probably gotten control of what's going on, and most of the people that they're now testing are negative because they've reduced those exposures. Here in Tennessee, we're sort of in the middle. Our positive rate, as reported by Johns Hopkins, is 8%. That's up in recent weeks, and we're doing about 2.8 tests per 1,000 residents in Tennessee. Here, just over the last week or so, we took on more than 10,000 new cases over the last week. So our recent average has been about 1,600 cases a day. And this is what the duration of the outbreak has looked like in Tennessee. So you'll remember that the stay-at-home order was lifted around April the 30th. And following that, we had this nice decline because we were still seeing the effects of that stay-at-home order. Then that was lifted, and then we actually had a low point in mid-June where we got down to a case positive rate of about 3.3%. But now we've had this fairly steady uptick over the last 3 weeks or so, and are back at 8.7%. The World Health Organization would really like to see everyone below 5%. We were there, but we've lost that in the last few weeks. When we look at testing overall, Tennessee is 11th for the amount of testing that they're doing in the state. We were at 13, so this has moved up a little bit in recent weeks. We've done about 14,000 tests per 100,000 people here, and we have a death rate of 10.1%. And we're getting ready to hit 1 million tests in Tennessee, which we'll probably hit over the weekend with the rate things are going, maybe even today. We'll see what those numbers look like at 2 o'clock. So compared to June 26th, we're now, these are the July 9th numbers from yesterday, up almost 20,000 cases in 2 weeks, with an increase of about 150 deaths, and those numbers have stayed double-digit for more days than not. And those hospitalized numbers have been growing along with the testing numbers. And this is the new heat map. You know, we continue to see large numbers of cases in the metropolitan areas, as you would expect. So Shelby County, Davidson County, Hamilton County has had a little more than their share of positive cases lately. Some of the rural hotspots are hot because they had large jail outbreaks, but are not reflective of what's going on in their communities. And then you have some counties that have just really not been affected much by this at all. They're doing testing. They're just not seeing a lot of cases, and that's because some of these are very low population rural areas, maybe 5,000 residents in a county, and so they're really good at social distancing for the most part. And this is a virus that needs a human host, and if it can't find one, then it can't spread. So you can see those low numbers in some of those more rural areas. So on the right is a testing map. So this is the rate of testing by 100,000 residents by county. So you can see that Davidson and Shelby have some of the higher testing rates. But then, again, just addressing the idea that more testing means more case positivity is not correct. So you have, yes, more positive cases, but the positive rate of those cases should remain the same if the outbreak isn't expanding. And so while Davidson County has the highest number of tests per 100,000 residents, they don't have the highest % positives among those tests. So that's Rutherford County that has about 75%, 60% of the amount of testing. I can't math today, Dr. Lynn. So their rate is higher. And then Shelby County, that has the second highest amount of testing in the state, has a positive case percentage of 7.7%, which is lower than Hamilton, lower than Rutherford, lower than Davidson. And so it does not correlate that just because you're doing massive amounts of testing, you necessarily have massive numbers or percents positive of those tests. This is what the hospitalizations are doing. So we were pretty comfortably in the 500s just a couple of weeks ago. Now we have passed 900 hospitalizations. These are active hospital cases. And you can see that the capacity for ICUs and hospital beds has now dropped to about 18% across the state. That's been moving in that direction, in that lower direction over the course of this week. Ventilators are still in pretty good shape. Isolation beds are starting to get a little more scarce, but most of these folks aren't put in airborne isolation. They're put in droplet precautions, so we would expect to see those airborne isolation rooms stay okay. Our death rate overall has dropped, which is a good thing, 1.2%. It used to be pretty solidly 1.7, 1.8%. 7.8% of the cases that are identified over the age of 61 have died. In long-term care facilities, it's almost 20% of the cases that are identified in long-term care facilities have died due to COVID-19. And we're continuing to see these growing cases in young people. We've been pretty solidly here at this 15% for those under 20. We're seeing a larger increase in numbers in the 30s and 40s as people continue to go about and not socially distance and infect one another. So a couple of headlines and hot topics. So Governor Lee did grant mayors the authority to issue mask requirements last Saturday. And since that time, these counties have done that. Davidson, Hamilton, Knox, and Shelby are all their own entities. They are under their own jurisdictions, under their own municipal governments, so they already had their mask mandates in place. But a couple of the counties, the rural counties, have issued mask mandates. Montgomery, which only applies to business employees. Robertson, which is only in public buildings. Sevier, Sumner, and Williamson are the other rural counties that have put that into place. And all of those are temporary. Most of them are going for about 2 weeks, maybe till August 1st, and then they'll reassess. The AAP, you might have seen, did put out interim guidance on school reentry and talked about how to mitigate COVID-19 risk, and the headlines from this have been misquoted in a variety of media sources. So what AAP said was that children are less likely to be infected, less likely to pass the virus on to other people, and less likely to become seriously ill from COVID-19. And all of those statements are true. What has been twisted in some of the headlines is that children don't get COVID-19, don't get sick, and don't transmit the virus, which is not true. They absolutely do. And it's very important that as we look towards sending children back to school, that to be able to protect them and the faculty and staff, many of whom in Tennessee are over the age of 50, and many of whom have comorbidities that put them at higher risk for complications from COVID-19, that we're taking every precaution in those schools to make sure that people can attend school safely. We did issue our guidance for recommendations for the management of COVID-19 in schools. That came out first the week of June 15th. Has already been revised a couple of times, and we'll update this every Monday as things evolve. But this is posted to our website. If you go to tn.gov/health, and then go to the coronavirus bar at the top, which is in yellow, and then to the education tab, you can find a link to this guidance. This is also on the DOE website. And along with AAP, we agree that it's critical that all district and school staff are prepared to contribute to the prevention, rapid identification, and mitigation of the spread of COVID-19 in Tennessee schools, and recognize that children learn best when they're present in person for instruction, and that if we can put things in place where people are wearing masks, they're distancing, they're staying home when they're sick, then we'll be able to have some semblance of in-person learning. Many of the rural counties in Tennessee, as I mentioned before, are very much unaffected by COVID-19 and can probably feel pretty good about having in-person learning. It's the metro areas that are hot, Shelby, Davidson, Hamilton, and the Mid-Cumberland area, Knox to an extent, that are really struggling with how they're going to be able to open schools and having to look at hybrid in-person and virtual options. Quick update on testing. So there's not really been any changes in the CLIA-waived platforms except for some changes in the EUAs. So the Abbott ID Now, which was the first of the CLIA-waived platforms to come out, has had to change their emergency use authorization to show that negatives should be treated as presumptive, and if inconsistent with clinical signs and symptoms, should be confirmed by a different molecular test. So if you're using that platform, just be aware that if you have someone who looks sick in front of you and your Abbott ID Now test is negative, you should really send out a confirmatory assay with a different lab. Q Health came on the scene about a month ago. They are also a CLIA-waived platform. Their negatives also should be tested with a different molecular assay if you have someone in front of you with clinical signs and symptoms of COVID-19. The Cepheid Expert Express, that does not have any of those caveats, has a national shortage on test cartridges, so while you can procure the actual machine, you can't procure the actual tests to use the machine. Hopefully, they're going to start to see some loosening up of that supply chain soon. And then the Mesa Aculair test, which also has EUA, we've not been able to figure out anything about where this company is or where their testing is, and we haven't heard, even our state public health lab hasn't heard of anyone using this test. So they're still listed as having an EUA, but I haven't heard of anybody who's actually using that platform. And then on the antigen side, there are two different antigen tests. One is the Quidel, that should say Sophia, SARS antigen test, which is a benchtop test similar to the rapid flu, rapid strep test that you're used to, but it does pop into the Quidel Sophia 2 reader for 11 seconds to be read. Those negative tests should be treated as presumptive and confirmed with a molecular assay if necessary for patient management. On a recent call with that manufacturer, they did report that they had some recent studies to show that their sensitivity rate is about 97.6% compared to PCR. So it looks to be a nicely sensitive test that may help out a lot with being able to give some quick answers in the clinic. And then the other one is this Becton BD Veritor system, which has just been given its EUA last week. And again, negative results on that test should be considered in context of the patient's exposure history and signs and symptoms, and confirmed with molecular assay if you need to. So we're going to talk a little bit with Dr. Adele Lewis, State Chief Medical Examiner, because we have a lot of talk about deaths and what is and is not happening with deaths in the U.S. and abroad. And so we welcome some of your comments this morning. Good to see you.
Nice to see you. I think I'm on.
Are you on?
I don't know.
There you go. All right, now we're on. So I have a couple of slides that I thought maybe we could talk about this morning. So this was pulled off of Johns Hopkins site with deaths per 100,000 population, and the U.S. is still pretty high up there. The U.K., I don't know what happened in the U.K. that they had such terrible deaths, although they have now come down the other side of their outbreak, as we saw in the Epi Curve slides before. But tell us a little bit about what's going on with deaths in the United States.
Well, first of all, there's a lot of chatter on social media that the death rate is declining, which is absolutely not true. The case fatality rate in Tennessee is declining, so that's when you take the number of deaths who have a known COVID positive test and divide them by the number of cases with known positivity, as opposed to the deaths per 100,000 per population, which is only increasing, and we are at 10, as you said earlier, for Tennessee. So if someone tells you that the death rate is decreasing, they are not correct.
So that's an important distinction. So the case fatality rate, the people who are positive, who go on to die, that rate is decreasing. And that is a result probably of knowing more about the virus, having some interventions that can be put in place.
Having some of the younger people getting infected too.
Okay.
And that's going to decrease our rate as well.
Okay.
So our case fatality rate is about 1.2%, which is lower than many other states. And I think, like you said before, a reflection also of our early testing efforts, that we really were full speed ahead to do testing on even asymptomatic people here in Tennessee.
Mm-hmm. But so this is saying that in the United States overall, we're seeing an increasing number of deaths per 100,000 people.
Yes.
Because not every state is the same, and not every state's reacted the same, and not every state's population that gets infected is the same.
Right.
All right.
Right.
As opposed to this, which is what you were just talking about,
right.
The case fatality ratio, and you can see that we're down, to 1, 2, 3, 4, 5, 6, 7, but like that whole middle pack there, we're basically all tied with Iran and Indonesia and Brazil.
Yeah, and so you can see that in Tennessee, like I said just a minute ago, our case fatality ratio is much lower than the U.S. as a whole. We're at, again, 1.2%, which is encouraging, and we'll hope it stays that way. But we're definitely seeing an increase in the number of deaths per day and per population.
Now, there's also been some headlines about the CDC saying that they might undeclare. How do you do that? You say that this is no longer epidemic status in the United States because the fatality rate is below, because COVID no longer encompasses more than 5% of the overall deaths in the United States. But the important thing about that is the lag time for death certificates and all that. And so this is a really small slide, and I'm super presbyopic. But so this is showing the deaths by date in the United States in the first column that are attributed to this is the number attributed to COVID. And then, so you can see by this as the dates go on that not only are people, according to this chart, not dying from COVID anymore, but they're just not dying, period. And so that's because there's a lag in when death certificates get processed and reported to CDC. And so those numbers in these more recent weeks just haven't caught up yet.
That is absolutely correct. And that's, we have a law in Tennessee that says the medical certification of death should be completed within 48 hours of the death, and very rarely are physicians compliant with that. We also, so that adds into lag time. The CDC is also being very careful with how they look at and code these, and so many of these COVID deaths are being assigned an ICD-10 code manually rather than by their computerized system. So that's taking them a little bit more time too.
And why is that? Why is that happening? Like, why wouldn't it be assigned by a computerized system?
The computer algorithm is written so that if a doctor writes an illogical sequence of events, so you're supposed to read the death certificate from top to bottom. So the last line that you use is going to be coded as the underlying cause of death. Unfortunately, we don't get taught that in medical school or residency anymore, and so people don't really understand how to do that. So you'll have something that says, like, atrial fibrillation, and then underneath it, it'll say metastatic bladder cancer. And I'm not aware of a causative relationship between metastatic bladder cancer giving you AFib. And so the illogical sequences get miscoded a lot of the time. And so they're being extra careful with this COVID outbreak and having actual nosologists look at a lot of the death certificates. So if you have to use the term COVID-19 or SARS-CoV-2 or novel coronavirus in the part 1 of the death certificate for it to be coded as a COVID death. So if you use it in part 2, that is considered by the epidemiologists as a COVID-related death, but it does not receive that underlying cause of death COVID code. So if you have any questions about how to fill out the death certificates, feel free to call our office and we will assist you with that. There's also a one-pager on the CDEP website under healthcare professionals about how to do the death certificates in these cases if you're interested.
Is that on our COVID website or under your
Yes,
app?
it's on the COVID website. It's on the Office of the State Chief Medical Examiner website as well, which if you Google OSCME, it will come up.
Okay. Or on the COVID site, go to tn.gov/health, go to the yellow bar at the top for COVID, and then go down to the providers box,
yes,
and it will be there.
It's in there near the bottom.
Okay. So does that mean if, so let's say that COVID-19 gets put into the section 2 of this, then would that be counted as a COVID death when it goes to CDC if you know, let's say nobody catches that, or do you know?
So the way that it works is every death certificate gets a single underlying cause of death code, and then up to 20 multiple causes of death codes. So it would show up in the multiple causes, but not in the underlying cause.
Okay. So, but it should still get counted, you think?
Yes.
Yes. Okay.
And it also gets counted, you know, there's a pretty high false negative rather, rate in these tests. And so if you are treating a patient and it looks like COVID and it smells like COVID, but their test is negative, it's probably COVID. So you can put presumed or suspected COVID-19 on that death certificate and it will be counted as a COVID death.
And that's an important point because there is a clinical case definition for COVID-19. So because of the false negative rate in the testing, if you have someone with signs and symptoms of COVID-19 who's a known exposure to someone with a confirmed diagnosis of COVID-19, then they meet the clinical case definition for a probable case.
Right.
And so that's really important to remember as well, that not everything hinges on the testing, just like not every person should rely on one negative test as being COVID-free. So as we said earlier on, if you have someone in front of you who has symptoms of COVID-19 and their test is negative, you probably need to repeat a test at some point and isolate them in the meantime and go ahead and have them notify their contacts to make sure that we're getting things under control.
So a really good question just popped up, which is, are we differentiating between dying from COVID and dying with COVID? And the answer is yes. So when you're filling out a death certificate, when you're trying to determine what's the underlying cause of death, you have to ask yourself, would this person have died at the time they did were it not for this disease process? So if the COVID accelerated their demise, that should be coded as a COVID death. However, in Tennessee, we have, I think, about 10 cases now of people who overdosed on drugs or got shot or were in a car wreck and they were COVID positive, and those are not by any means being counted as COVID deaths.
So do they all get reviewed?
I'm reviewing them all.
All of them? Wow, okay.
Since we're only at 700, it's doable right now, and I hope we don't have a big surge.
Right, exactly. All right, so we will look at the other questions that we have in here. So if you have questions, you're welcome to enter those into the chat box, and we can discuss those. So the first one is predictions for August and any guesses when Tennessee will peak. So I'm going to go back here to the Epi Curve. There. So when you have an Epi curve that looks like this, it's really hard to know when things are going to peak because this has just been all over the place, and it's not been kind of a nice curve like we're used to seeing. But if you look at not the blue line, but the bars going across, you can see that we've had this big uptick in cases. That does, yes, correlate with an increase in testing, and then sometimes there's a backlog with one lab, and so all of the tests that have been submitted to that lab end up getting submitted results to the state all at one time, so it makes for a big peak on a graph. Similarly, that one that's kind of underlying the 3.3%, that was a giant prison peak that did that. But if you just kind of look at the general trend of those orange bars, they've gone upward and over the last couple of weeks, and so it makes it really hard to predict when we're going to be out of the woods. And certainly with our case positive rate, that's a problem because those positives that are out there are continuing to spread to other folks who are going to spread to other folks. And so until that positive rate gets down again, it makes it hard to think that we're going to all of a sudden drop off to the other side of this by August. So obviously a lot of schools are looking very hard at this. I've had conversations with just about every university in the state, I think, over the last couple of weeks about their reopening plans, and they vary significantly from school to school. Some schools have gone completely online, at least for the first semester. All of them are doing at least some kind of hybrid plan with having some classes online and some classes in person. Obviously, it's more challenging for some classes than others to be online. If you have an anatomy lab or a chemistry lab, it makes it hard to be online. And so, but they're all looking at those strategies. They're all developing their plans for what happens when they have positive cases on campus and what that means for residence halls and where on their campus they're going to isolate individuals who are positive, how they're going to go about testing people when they need to on campus and trying to mitigate that in their own campus communities. So it's been the big talking point, I'm sure you assume, for every school and every campus and every district across the state and across the country and probably across the world at this point. The schools, likewise, are in a similar boat. The school districts in Sullivan County have a little different kind of impact than school districts in Davidson County or Shelby County or Williamson County or Sumner County that are surrounding areas that have a much higher case burden than some of the rural areas do. So that's what makes it difficult about guidance that comes out either on a national level or even a state level, because each school district and each county is a little bit different from one another, and their demographics are different. Their physical situation is different as far as the sizes of their buildings and their capacity to be able to distance, and whether or not they can have older kids on remote learning and younger kids in a lesser populated building for in-person learning. They're trying to work through all of these different details of their plans, and then also doing it while standing on quicksand, because this is just shifting constantly while they're trying to figure those plans out. So none of them are in an enviable position for sure at this point. A lot of the school districts have been releasing their return to school plans over this last week or so. There'll be some more that come out next week, and then I'm sure there's going to be modifications to all of those between now and when school begins.
You were talking earlier about the American Academy of Pediatrics recommendations. They just come out with a new, more sternly worded one today.
Yes.
I heard that said your decisions should be based on science. Even though we said that kids learn best in school, we don't want everybody to go to school right now and be fomites for this disease.
Yes, exactly. Yeah, and it's unfortunate, because again, when you write national guidance, it's really difficult to do. And so the message that AAP was trying to give was of the importance of in-person instruction, but not saying that in-person instruction doesn't need to have all of the safety considerations in place. And they also talked about masks in the initial statement, that young children may not be able to tolerate masks, may not absolutely need to wear masks because they are less likely to spread disease, but that doesn't mean that they can't spread disease. And so still, a second grader in Davidson County might really need to wear a mask. A second grader in a less populated county with a less of a case burden may be able for now to forego masks in that population. And if they're looking at not having mask wearing, that's the population to look at, is the preschool and early education age, because once we get into middle school and high school kids, those kids act just like grown-ups. They pass disease just like the adults do, and we've seen that with cases that have popped up in football teams across the state as they've returned to practice, and dance teams where people have gone to practice because they felt pressured to attend. They've gone while they're symptomatic, and then they've shared with their teammates, and they're quite capable of doing that. Next question is, if we continue to have ICU and hospital admissions persist at this level due to COVID-19, what capacity will exist to care for flu-related admissions later? If hospitals remain stressed at this level in fall and winter, will we surge? And so I think there's no question that that's the concern for fall. When we have 18% of our ICU and hospital beds available right now, that's not a whole lot of room for what could end up being a bad flu season. Hopefully we won't have a flu season like we had last year, when we had an unusual strain of flu that came through and started in Puerto Rico and Louisiana in July, and really caused a lot of havoc in those states. And if that right now, Louisiana is in a pretty bad situation with COVID-19, and if they were to have a similar scenario to last year's flu season, where they got a rogue B strain that came through in July, they're going to be in for a world of hurt. As I mentioned before, Texas, Florida, and South Carolina are already in surge, with adults being moved into their pediatric hospitals. So as we get closer and closer to flu season, it's a huge problem. So making sure that we are stressing the importance of flu immunization this year, even though it traditionally runs about 40% effective, depending on age range, up to 60% for young children. It does significantly reduce the need for hospitalization and ICU admissions and death. So even if people go on to get flu, they're significantly less likely to need a hospitalization, and that's what we're really going to need to focus on for this coming flu season. Will Tennessee do a free flu shot day again this year? How will messaging be done to increase vaccinations without people believing that they will be protected from COVID-19. So that's a really interesting point to be sure to message that if they get a flu shot, it's not protecting them against COVID-19. It's just making them less likely to be sick and think that they have COVID-19 and need medical care in a hospital or an ICU because of flu. So that's an important point. We are in the process of planning our Fight Flu TN event for this year. It will, for the last 2 years, for those of you who aren't aware, Tennessee has done a Fight Flu TN Day in November or December, where we've done a massive deployment of pods of on-site vaccination in usually non-traditional places like maybe a senior center or a firehouse or a school, and we've encouraged people to come get a flu shot. They get it at no charge, and we've seen that event grow. We use it for pandemic preparedness, actually, so that when things like COVID-19 vaccine come available and we have to give 6 million, almost 7 million people 2 doses of a vaccine over a 30-day period, we have some way of being able to manage that. So the first year it was done in 2019, we had about 110, 120 pods, vaccinated about 7,000 people, I think, in one day. Last year, we had about 220, 240 pods across the state, vaccinated almost 10,000 people on that day. The CDC is giving us a portion of $7 million of federally funded vaccine that we'll be getting this year, that we're able to distribute to places like community health centers, or college campuses and places that don't typically do a really good job of being able to vaccinate their populations because of cost barriers. So college campuses in Tennessee for the most part, can't bill insurance for immunizations. So when they try to do flu vaccine on college campuses, they have to charge the students for it. And sometimes that's not something that kids can do. I don't remember having $20 in my pocket when I was in college.
I don't think I would have spent it on a flu shot.
Yeah, probably would not have. And then community health centers, they see folks who are uninsured, underinsured, largely don't have TennCare coverage, and also those community health centers can't afford to purchase vaccine and give it to people. So we're hoping to get upwards of 150, 200,000 doses of CDC-funded vaccine that we're going to be able to give to those institutions this year, and hope to get those numbers up and include them in a Fight Flu TN event this year. That will probably extend beyond just one day, but we're still in the process of deciding what the public health part of Fight Flu TN will look like this year. But something will happen, and it will probably happen in October with a flu before boo message, that it's really important to get everybody their flu vaccines before Halloween. So look for more on that, and we'll update you as we get a little bit closer. In a pediatric clinic, should we be testing all patients with symptoms of COVID-19 without clear diagnosis of otitis, et cetera? So, yeah, this is going to be really hard for pediatricians because, you know, the bread and butter of what we do, starting about 2 weeks after school gets back, is respiratory illness. And you can almost look at the calendar and say, you know, we'll go back to school, we'll have about a 2-week quiet period where everybody stays away, and then that's about how long it takes them to all start getting each other sick. So the answer is yeah, probably. You're probably going to need to send COVID-19 tests off on these folks if they don't have another reason. And also remember that there's a pretty high co-infection rate with COVID-19 and other respiratory viruses, with strep, with other bacterial infections like pneumococcus. So it's going to be important that we get in the groove of sending off COVID-19 testing on those people who have respiratory symptoms, that they're isolated until those tests come back, that their contacts, they begin to think about who their contacts are, because it's going to be a bit of a mess this fall trying to parse out who's flu from who's adenovirus or enterovirus from who is COVID-19. And then the other fun thing that, and when I say fun, I'm being sarcastic, that we'll have this year is that this is also an AFM year, which is an acute flaccid myelitis year. So that's a virus that we're pretty sure is an enterovirus, a couple of different strains of enterovirus that come through every other year and cause that flaccid paralysis syndrome in children, where they just suddenly have 1 or 2 or 3 or 4 limb weakness. Some of those kids go on to have very significant disease, become ventilator dependent, permanently paralyzed, and this is one of those years as well. So we're going to have a lot going on in the pediatric world with this fall between these 3 viruses and all the other respiratory viruses. Next question. So many of these tests yield results with a recommendation that they be considered presumptive negative. Can a patient who tests negative be thought of not infected or not exposed based on any single test? So no, not really. So you can, and I think that's the messaging we've tried to get across for for this whole thing. When people have an exposure and then they go get tested and then they have this big sigh of relief, I don't have it. When really they're still in a 14-day incubation period, and at any point in time during that 14 days, they could end up positive. So as with any kind of test, your predictive value changes depending on what the burden of disease is. So if you're in an area that's doing drive-through testing and all kinds of asymptomatic people come in and there's relatively 0 transmission in the area and you get negative, those are more believable negatives than if you are doing testing of currently symptomatic people in a hotspot of COVID-19. So depending on where you are and your concern for COVID-19, you should be doing a second test, whether that's a test in 24 or 48 hours, or doing a different assay. If you're doing maybe a benchtop clear wave test, maybe doing a send-out one, either the same day or on another day, is going to be really important to make sure that we're giving accurate information to people and that we are having the opportunity to isolate and quarantine those people that have been sickened and exposed. So if the person in front of you is getting a test because you have some concern in your head that this could be COVID-19, then that one negative should not be the thing that you're hanging your hat on. This one's for you. Can you clarify the case fatality rate?
Right. So the case fatality rate, and you can also call it the case fatality ratio if it helps you think about it better, is the number of people who have died from the disease, divided by the number of people who have been diagnosed with the disease. That's different from the mortality rate for the disease, which is 10 people out of every 100,000 people in Tennessee are dying from COVID.
Okay, so the mortality rate is population-based. The case fatality ratio, I like ratio better because it does make it a little more clear, is the fatalities of the cases. That's why it's the case fatality ratio.
Right, so those are 2 very different numbers.
Yeah, so do you know what the typical death rate, case fatality rate for flu is?
I was just Googling that. Good thing you asked.
Huh. Google.
Yeah, Google.
Google to CDC probably, or something along that line.
What I've heard is that it's about 0.1% for influenza, so 1/10 of what the Tennessee rate is, 1/25 of what the national rate is.
Yeah. I know I was crunching some numbers this weekend about pediatric deaths in COVID-19, and someone had made the comment that that children that they die disproportionately from flu, which is not true because they make up about 22% of the population in the state, and we have something like 0.04% of a mortality rate from flu in children. So it's very, very low, whereas the case fatality rate among children in Tennessee for COVID-19 is something like 0.4%, which is higher than what you would expect from flu.
Mm-hmm.
So we don't track the case numbers of flu in Tennessee. You know, they do some national surveillance work, and, you know, we have our surveillance providers that they base that data off of, but we don't track every single case of influenza in the state or in the country. There are some states that do, which I don't even know how they do that, but we don't. We track pediatric and pregnancy cases from flu. So, for example, this past flu season, we had 11 pediatric flu deaths. We don't know how many cases we had, but you can bet it was on the order of thousands, if not tens of thousands of cases of pediatric flu, whereas right now we have something on the line of a few thousand cases of COVID-19, and we've had 3 deaths. So the mortality or the case fatality rate in pediatrics is higher for COVID-19 in Tennessee than it is for flu in Tennessee.
Right, and so that's another plug to be accurate when you're doing a death certificate, because where do we get all of these numbers? We get them from the death certificate. So I think that's one reason why we can't track flu deaths, is they don't materialize on the death certificate 9 times out of 10.
Yeah. In the THON yesterday, which is the Tennessee Health Advisory Health Alert Network, yeah. Yesterday, it recommended eye protection in addition to standard precautions. Does this mean safety goggles, glasses, or will face shields be acceptable for that? Yes, face shields are acceptable. Eye protection, absolutely. They're cheap, they're easy to get, you can clean them, which is great. There is a public misperception, though, that face shields are a substitute for face masks or cloth face coverings. And we have this fight a lot in the school systems where we have professors in a college who will say, well, I can't effectively teach with a cloth face covering on, and so I just want to wear a face shield. Or we have teachers in schools who say that, well, I don't want to wear a cloth face covering, so I'm going to wear a face shield instead. And they are not the same thing. So a face shield protects the eyes of an individual who's wearing a face shield. A face mask protects the people around the person who's wearing the face mask. So they are not interchangeable. You can wear a face shield with a mask, or you can wear a mask without a face shield, but you can't wear a face shield without a face mask and expect to really be doing anything. And what are your recommendations for albuterol treatments when the wheezing-associated respiratory infections arise? Great question, especially in pediatrics. So the guidance around albuterol for a good bit of time is that MDI is just as effective as giving a nebulizer. So you can do an MDI with a spacer and mask on a child, and it's more puffs. Usually they do something like 8 or 16 puffs of an MDI for a child via face mask and spacer, but it is not then a aerosolizing procedure, and you don't have to worry about full PPE and really worry about having to protect yourself as much as you would if you were doing an aerosolizing procedure like using a nebulizer. So good question. Get MDIs. I know there was some shortage of MDIs at the beginning of the pandemic for this very reason. So if it's something that you're anticipating needing to do, which every pediatrician is going to need to do, that's something you probably want to look at starting to procure for your practice sooner rather than later. So that brings us to the top of the hour, and we've gotten through all the questions that you've submitted so far for us today. So we hope that you'll come back and join us again. We're going to move these webinars to an every other week webinar so that we can do a little more in the way of newsworthy updates for y'all and give some higher level guidance, we hope, and also give us a little bit of bandwidth to be able to do the ever-increasing work that is happening here at Department of Health. So come back and see us in 2 weeks on Friday at noon. We'll send out the link to all of you when we get that up. This webinar will be posted to our webpage under the Provider tab, just as it is every week. And we will talk to you soon. Take care.